board certified in both family medicine and addiction medicine. She is the most recent public health officer for Humboldt County and clinical champion for the Humboldt Rise Project, which is a county-wide perinatal substance use disorder project and Humboldt County's jail mat program. She's worked in primary care in rural Northern California since 2006 and sees every day how the disease of addiction affects her and the individuals and families in her community. I met Dr. Stockton at a conference early in the Hub and Spoke project, and we were in a small group discussion together, and I was so impressed by her knowledge and accessibility. I ran after her at the conference. I was like, Dr. Hello, excuse me, pardon me. Would you like to work on our project? Would you? And she was like, who are you? No, she was very nice, but she was busy. And then I stalked her for months and was able to get her to agree to be a consultant with us at UCLA, where she's done a number of trainings, mentored many, many clinicians. She is a champion for MAT treatment, for people in the community who need champions. And I can't be more delighted to see her in person and introduce her to you today. Enjoy.
Thank you. That's going to be hard to live up to. What Gloria didn't tell any of you, of course, is that at that time I was shocked that anybody would want to talk to me about anything, because I certainly did not consider myself an expert. And I always wondered how people got to be experts. And I have now figured out the formula. You say yes the first time somebody asks you to talk, and then the next time they think of who have I heard talking, they think of you, and pretty soon you're the only person anybody here is talking anymore. So I apologize if some of you have had to sit through me talking in the past. I am excited to be here today and do what I do best, I think, which is actually share stories with you. Let's see if I can figure out how to get this to advance. So many of the talks that you'll hear today, you'll hear a lot of science, evidence basis, stats, numbers, facts. You're not going to hear a lot of that with me today, because we're going to talk more about the power of sharing our collective stories and how we change our communities, not so much how we point to evidence-based treatment, although evidence-based is really important. I'm going to give you a little bit of my timeline background, because many of you look quite a bit younger than me. And depending on when you entered this work, the milieu around us was very different. So I finished residency in 2004 in Florida. And my training around like the potential for opioid misuse and addiction and how you did that kind of stuff was one sentence in residency. I had a attending provider who told me, oh, when people come in and they ask for pain medications, you just write them 100 of whatever they want and tell them that when they want a refill, all they have to do is call. And then when they call you, you wait and see how long that was. And you ask them what pharmacy they want their refill called to. And then you can call the pharmacist and ask them what they're getting. That was the extent of my training around the potential for misuse of opioid medications when I was in residency. And that was pretty typical. That wasn't unusual at the time. So I moved out to California in 2004 and applied for my state license here. And as part of that, I was required to take a 12-hour training on pain managements and patients' rights to pain managements. And basically that training said there is no upper limit above what you should not prescribe opioids. You should prescribe whatever it takes to adequately control the patient's pain. And by the way, there's this thing in California called the Pain Patients Bill of Rights that legally entitles patients to request opioids from you, and you cannot tell them no. If you're unable to prescribe them for some reason, you have to hook them up with another doctor who will. So you can understand maybe why you get some pushback from older physicians now when you're talking to them around safety and prescribing, because the law actually states we have to. There were doctors that were prosecuted for not adequately managing people's pain in the same way they're being prosecuted now for giving out opioids. And so we're caught in the middle of this whiplash. In 2006, I left practice in Southern California. I joined a kind of cushy HMO, highly insured, highly educated, highly employed patient population. And I was surprised by how many people needed opioids and how aggressively they asked about them and talked about them, because it just hadn't been my experience before that. And I moved to a rural clinic in Northern California in a county that has a population of under 30,000 people, and headed up the clinic there and quickly learned that I could not stand pain patients. It was the worst part of my day, and every interaction was a fight. I lasted about 2 years in that job. And then I went to another rural clinic in a county that had a population of 180,000 people, so a little bit larger. And I took over leadership of the clinic, because it turns out that if you're, alive, have a pulse, and an MD after your name in small rural counties, you can move up the leadership chain really fast. And so I started to recognize this as more and more of a problem. So I actually did something that was unheard of in 2006. I implemented mandatory drug testing on patients who were receiving opioids. No specific rules about them, just mandatory drug testing. And in my first 3 months, I identified 12 patients who were testing consistently negative for the drugs they were being prescribed, collectively had a street value of $220,000 a month. How do I know how much that was worth, you ask? I asked my patients. How much does it cost you to buy one of those? So again, though, my CEO at that time, when I said, we're going to fire these 12 patients, we're not going to continue prescribing for them, we're going to fire them. And she said, oh, that's great. I'm really supportive of the change that you're making. Okay, what she actually said is, well, we'll lose money from those visits and we could go out of business. I don't think you should do that. I thought, well, there's going to be some guidelines around this. I'll just look up the guidelines. I'll figure out what the guidelines are. So in 2007, do you know what guidelines were available about pain management online? Professional recommendations. There was one, and it said you probably shouldn't prescribe more than 100 milligrams of methadone per day to an individual patient without getting a pain management specialist involved. Now ask me how many pain management specialists there were in my county. That is 0. Yes. Yeah. Right. So this is the backdrop that today's physicians, or older physicians at least, are coming into this situation with, because this is what we were taught. This is what the law told us we had to do. These were the regulations that we faced. 2008, 2009, I started realizing this was more of a problem. In 2009, I got my data waiver. I didn't really know what it was at the time, but somebody offered me the training, and I was really fed up with opioids, and I thought, I'll go do this. And I messed around with prescribing bupe out of my office, the only prescriber in the county who was doing it, for about 6 months. And I am a good student. So I paid close attention to the trainings that told me you will treat your patients for 6 months, they will get better, and then you will taper them off this medication and they will not need it anymore. And because that's how everything else in my practice works, right? I mean, my hypertensives do that, my diabetics do that. I just treat them 6 months and they're well. I was like, yes, this is going to work. And then I said to patients, this doesn't seem to be working. And I have done the trainings, and I've paid attention, and I've read the books, and I've talked to the drug counselors, and I'm so sorry, but you are not trying hard enough. And I cannot afford to give this limited space I have, 30 spaces, 30 people I can treat in the entire county. I cannot afford to give this space to somebody who is not trying. So I'm going to let you go. And when you hit bottom, if you live through it and you want to come back, you come talk to me again. Because, right, letting people hit rock bottom so they learn how bad this is, right? This is absolutely going to change their ways, because it works in so many other things that we do in life, right? And all this time, everything that I'm telling you, I am exactly following the teaching, the training, the regulations that are present at that time. I mean, I could try, but I'm going to give everybody motion sickness while I wiggle. So in 2013, after I had given up treatment, I got a call from a colleague who was an OB provider who worked in our area. At the time, my county had no methadone clinic. The closest methadone clinic was a 7-hour round trip drive. And there were no prescribers in the county who were prescribing buprenorphine, period. I was one of, I think, only 3 waivered providers in the county, but none of us were prescribing anymore. And he said, I have this patient who's pregnant, who's moving into the county, and she's on buprenorphine and she needs treatment. And I know you're waivered. And I said, oh, hell no. No way. Don't even get me started about my OB experiences in pregnancy. If there's one thing I don't like more than an addict, it's a pregnant woman. They scare the hell out of me. Not doing it. No way. All the way up to the minute she was sitting in my office and I was writing her prescription. Having no idea what I was doing, but my empathic self could not turn away a pregnant woman who did not have any other access to treatment. And legally, I was the only person in the county who could treat her. Her daughter is now 11. I moved away from that area 5 years ago. She still keeps touch with me and sends me pictures on Facebook. Doing amazingly well. She was also my first and only repeat customer. So her son is almost 7 and also doing very well. And she frequently reaches out to me and tells me that I changed her life. I will say that is not true. She changed her life, but she changed my life in the process too. And that was kind of the start of my process with this. So in 2017, I was one of the first group of people who took the addiction medicine boards when the new addiction certification came out for ABMS. In 2018, I became addiction certified with the first group of providers. And that has really shaped the work that I have done for the last, 10 years or, now, but specifically the last 7 years, my work has really been focused around this. I am still terrified of pregnant women. Don't get me wrong, right? I'm still terrified of pregnant women, but some things are worth facing our fears for. So by Dr. Stockton or Candy, either is fine. I am the health officer for Humboldt County. I started that position about 6 weeks ago. No, I am not crazy. Yes, they offered me the opportunity to really head up this work across the county because for 10 years, I've been telling pregnant women and their families, it's not fair that the system treats you like this, but this is how it treats you. So let's figure out how to work around that. Now I get to tell the system it's not fair that you treat people like this. We have to change. And that for me is worth it. So I have no financial disclosures. I have a whole lot of political disclosures, but fortunately I don't have to share those. Welcome to National Recovery Month. I admit that I have somewhat mixed feelings about these kinds of terms. I am a family medicine doctor by training. I treat people with chronic diseases and chronic health states, right? And I don't expect any of them to be cured or miraculously better. I recognize that some of us have health issues that are challenges to us, and we will manage those with varying degrees of success over the course of our life. So I'm a little iffy on the term recovery because I think it can convey a lot of expectations with it, but I'm a big supporter of supporting people in their improvement, in managing their chronic illnesses, in their right to dignity and ethical care, regardless of what choices they make. And I think any gestures that we make in that direction are incredibly valuable. So I am going to talk to you today about how we use our community connections, our coalitions, actually change attitudes and increase access to treatment in our communities. And this is going to be, I hope, a very interactive talk. I'm going to be asking you questions about what you have in your own community and what you've done, along with sharing my own stories. But I'm hoping that from today, you'll walk away with some ideas for how you can leverage your coalitions if you have them already, or start them if you don't, to help increase access to treatment for people. And by treatment, I don't just mean pharmacotherapy, right? I mean all of the aspects of treatment that are important. Pharmacotherapy is key. It's a critical one, but some people don't want pharmacotherapy. Some people don't want to quit using. Some people, just aren't ready to have that conversation, and they're still deserving of treatment and care from us. We're going to talk about how you incorporate equity and diversity into the work that you do, and talk about at least one way you could expand your current coalition work. Again, no financial disclosures, but I do have some slides that represent work that I did in Shasta County before I moved to Humboldt County, and so you'll see information from both of our county coalitions. So, a couple of key activities: assessing local capacity and resources, capturing grant funding for work done in the community, and stigma reduction. Healthcare of all forms is siloed. I don't have to tell you that, I'm sure. When I first got into doing work around addiction, I would say to patients, you have to see a counselor, That was also required in the guidelines, by the way, back in 2009. You have to see a counselor to get this therapy. I have to sign that I've told you that. And patients would say to me, I have Medi-Cal. There's nobody that takes my insurance. And I'd be like, well, that makes sense because nobody takes Medi-Cal for anything. Yeah, so basically every county addiction service in the world exclusively or only or preferentially takes Medi-Cal patients. That's not true, right? That there was no one they could see, but I didn't know who those resources were. I didn't know that work was being done in my county, right? So one of the first things that coalitions can do for us is to actually bring all the people who do this work together so that you can learn what you don't know. There's probably a lot of work happening in your community that you don't know about. Sorry. There's probably a lot of work happening in your community that you don't know about. And I'm not saying that, patients will mislead you and try and fool you, but what I am saying is you will not be a very good advocate for your patients, for your clients, if you don't know what the resources are that can help them. So I'm not going to dwell on this a whole lot. I mean, but it's just kind of self-evident that unless you get the people who are doing the work together, you and your silo are not going to know what other work is being done. And that involves a broad range of people. It's not just medical providers. It's not just treatment programs. It's people who provide housing for homeless individuals or who work with low income housing. It's food resources. It's transportation resources. Like I can't get to treatment if I don't have a safe place to leave my child. I can't get to treatment if I can't leave work because I don't have food if I'm not at work. So treatment becomes secondary to all these other resources. And we really need to figure out how to work these things together and help people access that. Coalitions can be a great unit for leveraging funding. So many coalitions early on in the process, before the last legislation passed that required drug companies to clean up their mess and pay for drug take-back boxes, a lot of these drug take-back boxes were funded through coalitions in communities. Your communities may have done the same thing. And in the counties I've been in, this was the only source of drug take-back boxes. They were all funded through grants that were obtained by our community coalitions. The Humboldt RISE project, which was our resilience and inclusion through support and empowerment. We worked a really long time to come up with a cool acronym for that, so I hope you like it. Was our perinatal substance use project. And through that project, we were actually able to implement screening at every OB point of contact in our county. Every woman who came in was screened not for substance abuse, but for risk factors for substance use and misuse so that they could be connected with supportive services early on in the pregnancy. Because as you know, if the time that we identify as your substance use disorder is in the delivery room or when you check into the hospital, gives us very little time to put any kind of support measures in place. So we were able to move that process up so that we were identifying it as people were coming into care. Does everybody connect with services? Do they have to? No, it's a voluntary program. But it gives everybody the chance to be offered those services and to make that relationship with something else that was funded through grants we got for this project, our perinatal substance use navigator in the county. I know many of you from larger counties are from larger counties and will laugh when I say we have a perinatal substance use navigator in our county, but still, it was a big step for us, right? Because most care coordinators are co-located with the hospital or healthcare system or a particular organization. Having somebody that could track the patients across all of those locations was huge because people don't always stay in the same healthcare location, the same medical office, have the same needs. And of course, if you're a social worker for the delivery hospital, you're probably not available to help with supportive housing for a woman who's 3 months pregnant, right? So this was a huge thing for our county. Again, all funded through grants that we got through our coalition. So these can become really important places to actually apply for and fund projects that overlap multiple organizations. I'm curious, I'm assuming that many of you have coalitions in your county. I can see a show of hands, like how many of you know if you have a coalition in your county? All right. Most counties in California have a coalition where work was funded through CDPH at some points in the last 10 years. So if you don't know, that might be a place to start when you go home is what is your opioid safety coalition? What work are they doing? How could you be involved? Those of you who do know you have them, or do you have any other examples of projects that your coalition has gotten funding for? Yes. Awesome. Yes. Oh, I'm sorry. Repeat it for me one more time. A town hall project for So a town hall meeting for the fentanyl crisis in Shasta County. And?
We have like a youth project. We have we do Narcan training. We've gotten funding for a lot of things, and I work for the SOAR grant. Before I was at MedMark on the SOAR 1, and then now our coalition has picked up my position, so I'm through the grant and I'm working for the coalition.
So in Solano County, and I'm going to try and summarize that, they've funded positions to actually coordinate programs at various organizations. They have a youth program, and I lost part of it. I'm sorry.
So
Narcan trainings. That was the other piece. Yeah.
24/7 crisis hotline for people with addiction.
Ooh.
I run and hook them to services or give them like a patient navigator.
I love that one. So patient navigator, but the other part of what she said was a 24/7 crisis line for people seeking services. So that's incredibly valuable. Anybody else? Anybody online? Okay. How about that? Okay. So another important piece of the work that we do is stigma reduction. This is a baby that was born addicted to drugs. Don't you love that term? This infant's mother injected 4, 5, 6, 7 times a day large quantities of drugs. When baby was born, she was alternately lethargic, irritable, fed poorly. She required medical intervention Q2 hours for the first 4 days of her life in the ICU. How do you feel about her mother? Yeah, right? That is my baby. I had gestational diabetes, severe gestational diabetes. I required insulin injections 7 times a day. I was on over 500 units of insulin a day by the time my baby was born. My baby was born addicted to drugs because I had a medical condition, and she required intensive care and support to keep her alive and to keep me alive. How do you feel about that mother now? Right? Why is that different? Why do I get grace and acceptance for my medical condition when I got pregnant and other women who have medical conditions don't? Right? Stigma. But throwing it in people's faces is a really effective way to make them face what they believe, right? You can look at that baby and think one thing when I present the facts a certain way, and you can look at that baby and think something else when I present the facts a different way. Collectively, our coalitions give us a way to leverage our stories, to share our stories, to see what works to change opinion, to share those stories across a broader range, because it is not enough for me to tell pregnant women that this is not their fault and that it's not fair the system treats them this way, but it's just what they do. And just walk away at the end of the day and think I did good. We have to change the systems. And we can't change the systems with facts and statistics and data. We can make inroads. We can force some changes, but we can't change the way people feel about the patients we're treating with facts and figures and data. We have to change the way people feel about what they're doing with stories. And our coalitions give us avenues to do that. They give us avenues to hear stories from the people who participate in them, give us avenues to share those stories out with other people. So the next time you look at a baby in the ICU and say, this baby's sick in here because her mom injected drugs 7 times a day. So lots of women who have chronic diseases get pregnant and have babies. What do you want her to do? You want her to get an abortion? You know, she has a disease. We need to address it, and we need to extend to her the same caring, empathy, and compassion that we would give to any other woman with a disease. And so when my second child came along and I ended up comatose on the floor 3 different times, no one told me that they were going to call CPS because my other kid wasn't safe at home. No one actually even offered to help me, which in hindsight is a little bit scary, but certainly nobody targeted me or penalized me for having that disease. And, you know, unless you say it's different, why? I knew exactly how bad my first pregnancy was, and I made the choice to get pregnant again. And I can't even pretend it was an accident because I was on fertility therapy the whole time. So I willfully made a choice to endanger myself and the potential baby that I was carrying because I wanted to have another child, and I had a chronic disease. End of story. What else do we do? Training for providers, networking providers and provider support groups, and connecting resources and information for providers. Because if you want to increase treatment, it's not enough to just increase the number of providers who are licensed to provide treatment. You actually have to give them some ability and willingness to do that. So what are some of the things that we did? We did everything we could think of, actually. We held local conferences. We sponsored didactic trainings in the residency programs in our local communities. We link people to statewide trainings and circulate through our networks the trainings that are available through the ORN, through all of the various, networks that we're plugged into. And we go to specific training or specific programs and present targeted trainings as requested or as needed. So I'll tell you that I am incredibly proud of the fact that every hospital in my county that handles deliveries practices Eat, Sleep, Console as their primary mode of treatment for every baby that's born to a mother who uses substances in our county. This is a huge change that we've put into place in the last 5 years. And a large part of this is our willingness to get out to organizations, to talk to them, to change minds, to provide support, to be somebody who's available to pick up the phone call and answer that question when a provider has a question. Not me and my pathetic, I have no idea what I'm doing with pregnant women or addiction treatment, but sure, I'll take your patient and do that first one, right? And not an expert who's located someplace else. And that's important because when I called experts in the beginning, I got things like, that sounds like a patient for a methadone clinic. Lovely, but I don't have one. What am I supposed to do? Oh, you need to send her to a higher level of care. I am not only the highest level of care, I am the only level of care in my community. What do you want me to do about that? Well, why don't you put her in the ICU to do an induction? Yeah, so my hospital actually won't accept patients for that, and we barely have a functioning ICU. So having somebody in your community who understands what your resources, your situation, your providers, your reality is so critically valuable to providers who are starting out in treatment. And this can become a really important resource. Now, I have to say that, it's not very good. I have made it my mission in life to put this slide in every training that I do for the rest of my life. This is me diving with whale sharks in Mexico this summer. Best moment of my life. But I found a tie-in for you. So here's what it is. When I was telling people I was going diving with whale sharks, most people got this panicky look on their face and said, boy, that's really scary. And as I explained to them that whale sharks actually don't have teeth, they have baleen. And in fact, their throat is like this big around, so they couldn't swallow me if they tried, even if they couldn't chew me up first, right? It became less scary because people just heard the word shark and shark was scary. And they're like, how big are they? And I'm like, 30 feet long. It's amazing. And they're like, that's really scary. And I'm like, no, they're very tame. They have no sharp teeth. It's all fine, right? As people learn the facts of things, it becomes less scary. So that's my tie-in. Thanks for bearing with my brag picture. So what did we do? We created a group, and I cannot claim the name. That came after I left the county and another provider took it over. He called it the X-Men group, X for X waiver, because of course doctors are have very amazing senses of humor. So we actually met once a month. We had dinner back in pre-COVID days when you could see people face to face, and had dinner with the providers and programs in town. And this was critical for Shasta County actually because it occurred as programs were starting at different locations. It was the very beginning of treatment in our county. And it allowed us to do two things. It allowed us to actually talk to each other at the different sites about what we were doing so that we could align our treatment principles, and it gave us a sense of safety in that we could ask other people, like, this is what we think we're going to do. How does that sound? So if you ask what you're responsible for as a provider in a community, you're sort of responsible for following something called the standard of care in your community. Well, when every provider in your community, or at least representatives from each program, are meeting in the same room and talking, you've just become the standard of care in your community. So it allows for that sense of security for providers who are starting out to feel like they're not alone, to ask informal questions, and also to feel protected from a legal standpoint that they're following the standard of care in their community. It's also how we actually ended up going from having no providers in Shasta County who would treat pregnant women to having one of the highest X-waivered provider to population ratios in the state, actually. So this was a huge process for us that actually allowed us to expand treatment, and it just kind of exploded in Shasta County over a 2 or 3 year period from zip, nada, zilch to basically treatment programs in all of our FQHC networks, our OB offices, and actually having access to treatment. So this is really important. You need administrators on board, you need support from your organizations, but you also need providers who are willing to write the prescriptions and are willing to do the treatment. And so this is a way that your coalition can fund that. So question for you guys. When I first started this, it was really common that the traditional treatment programs in the community, the residential treatment programs and the intensive outpatient treatment programs, would not actually accept patients who were on buprenorphine or methadone in their programs. How many of you still find that true? Has that mostly changed? What county are you in? Sacramento County? Yeah, we definitely had that problem in both Shasta and in Humboldt counties, and I can't speak to the situation in Shasta right now. I know by the time I left, most of the treatment programs either would accept them or were on the cusp of accepting them. But I know when I started talking to them, it was like a no-go, zero acceptance. Humboldt County at this point, basically all of our, I'm going to show my bias here, our real treatment programs who will accept patients on medication. There are some various smaller, some religious and philosophical organizations that will not accept medications, but most of our like established treatment programs will at this point. And this is a change that in large extent the coalitions have had in counties by actually sending providers, people who do this work out and talking to those treatment programs over and over again and saying like, A, you're wrong. B, this is why you're wrong. C, what you're doing is illegal and a violation of the American with Disabilities Act. D, here's my phone number. If you have questions and you want to talk to me about how this works or what it looks like or why this isn't bad or why it's okay, I will take your call. It turns out that, at least in the treatment community, which has been disconnected from the medical community for a long time, a doctor passing out their phone number is pretty powerful, right? And of course, I and the other doctors involved in this held true to our obligations and actually responded to their phone calls and answered questions. But that connection can be really powerful for change. And then the last question is, who supports or mentors new providers in your community? When somebody either moves into your community, say they were an established provider before, but they're new to providing treatment in your community, or maybe they've been in your community a while, but they're new to providing treatment, what resources do you have for them? Who supports them? Who can they call? And I will tell you that in my experience, this is as true for nurse practitioners and PAs as it is for doctors. None of us like to ask questions in front of audiences and look like we don't know what we're doing. Because there's always a fear we should have known the answer to that, and looking less than fully informed in front of public audiences is terrifying to a healthcare provider. So having that access to somebody who knows the landscape locally, who understands treatment and is willing to connect with them can be super important. There are other ways to do this besides local coalitions, but local coalitions are one of the most effective ways. You'll figure out who your champions are, right? You'll figure out who the people are who just can't shut up about addiction treatment and are always happy to talk to anybody anytime about it because they ethically believe it's the right thing to do. I'm sure you have a couple of them in your county too. I'm not the only idiot out there. So, but coalitions can be a really good way to identify these resources. Another thing that came out of our coalition was actually, this conversation about I'm too busy. I'm a healthcare provider, I'm too busy. I don't have time to figure all that out. I don't know where they can go for treatment. Oh my gosh, there's all these different insurance types and there's all these different programs and I don't know who can arrange transportation and I don't know, right? So some of that is just people not wanting to take the time to figure it out, regardless of how busy they are. But some of it is legitimately difficult to figure out what resources are available, what's still there, what's up to date. Those printed phone lists from 5 years ago don't work when you call the numbers. Really difficult. So in my community, one of the things our coalition has done is actually created the North Coast Resource Hub, which is actually a comprehensive listing of all of our service-related stuff. It started really with substance use and expanded out from there to include other things at this point, and has been successful enough in our county that 2 of the smaller local counties have contracted with us to actually include their resources as well. And I don't know how you can see this, but you can search it by category, what you're looking for. One of them is addiction services. That's what I selected. You can select subpopulations. In this particular one, I've selected Native Americans and pregnant people. as categories to narrow the search by because we have a large Native population in Humboldt County. And then I've selected Medi-Cal as an insurance type, and you just punch those things in and it will give you a complete list along with up-to-date contact information and more detailed information about what services each of those programs provide. So if I'm a busy provider, or I'm a new social worker in the county, or I just changed jobs and this wasn't my job before, I have a way to access that information quickly, accurately. And the state databases do have some of this information, but they're not really as specific to our communities. Maybe that's different if you're in a really large county and has somebody keeps it up to date, but what we find is what was pulled out of the state databases just isn't effective for telling us locally what's available, and this is a much better way to do that. This is a project that was actually grant funded through our coalition as well, and has become actually its own self-sustaining revenue source now because of the contracts we have with other agencies to keep it up and running for them. What else do we do in coalitions? Harm reduction, naloxone training and distribution, promoting harm reduction. So I don't love this, but early on in the coalitions, one of the things that we were funded for through CDPH was actually academic detailing. So for those of you who are not familiar with that process, that was back, we had this idea that the reason we had a problem with opioids was because doctors were writing too many prescriptions, which is part of the problem. I'm not going to deny that, but that's not the reason we have trouble with opioids. I mean, doctors could write prescriptions for Kool-Aid all day long, and if it didn't make you feel better and you didn't want to drink it, you wouldn't. Trust me, I know I've written lots of prescriptions my patients have never filled. So yes, that was a problem, but it wasn't really the root of our drug problem in this country. Nevertheless, we were provided information on which providers in our county were writing higher than normal amounts of prescriptions, and trained to go into their offices and talk to them about their prescribing practices. Because you know those guidelines I said that didn't exist for opioid prescribing when I was looking for them? In 2014, November of 2014 is when the California State Medical Board came out with their first opioid regulations. And then in 2016, a year and a half later, is when the CDC came out with their recommendations. And suddenly, doctors who were following the law and writing the opioid prescriptions that were required to write by law under the Patient Bill of Rights were actually being prosecuted for writing prescriptions that the same medical board and government had required us to write in the first place. And you can imagine the whiplash from that was pretty dramatic, and there was a lot of resistance. So being able to go in and talk to doctors' offices and train them on the opioid guidelines had some benefit, maybe, possibly. It is one of the things that many of your coalitions will have done. It might have been a benefit in your community. There may have been some providers who really did need to be reached. It might be a harm that your coalition did in your community that you now have to actually walk back from and overcome. So it's important to be aware of that. I'm not going to say it's hands down a success, but it's a thing, and coalitions did it. We were some of the first organizations to promote and distribute naloxone in our counties. So Shasta County, again, this is Dr. Bosworth, and I forget the name of the officer involved in the project, but this was actually our partnership with Reading PD to actually put naloxone in their hands. Sometimes that was easy. Some of the organizations came to us and said, we heard about these pilot projects that are happening in San Diego, and we think we want to do this too. And some of them were hard. There were a couple of law enforcement agencies in Shasta County that we lobbied for 3 years to encourage them to see the value of naloxone. And I will share with you what I learned from that experience. I never got them around to thinking it was a good idea to be able to have on hand because somebody might need their life saved. What I did get, though, was, you know, that fentanyl hysteria that people have? There was this story about police dogs that were sniffing fentanyl and, you know, on the raids and stuff and dying. And that's when they figured out that you could actually use Narcan on police dogs as well, which was the last trigger that tipped the last agency in our county over the line into being willing to sign up to get Narcan training. I'm not sure how I feel about that. I don't feel good about the fact that they were willing to do something to save dogs that they weren't willing to do to save human beings. I'm not really a dog person myself, full disclosure, but you know, I do think though that it takes a special kind of horrible person to be holding something in your hand that could save somebody's life and refuse to use it. So however it got in your hands, at the end of the day, I don't really care. And I share that story because I'm encouraging you and your communities to listen to what matters to people and use that to motivate the change. And that's another thing that coalitions give us. We spent years having these conversations with them before we finally found the in that was a thing that mattered to them. And you know what? I took it. A little ashamed of it, but I took it. After that, we also did trainings and distribution. We did them for the general public. We did them for library staff. We did them. And this was actually my first entree into those treatment programs that wouldn't allow bupe on their sites. We actually did trainings for naloxone for treatment programs so their staff could have naloxone and carry it themselves. And that was the place I got to open up those conversations about why maybe we should be talking about using bupe in treatment programs. So a lot of potential to make connections. And oh, questions for you guys. How many of you know if law enforcement in your community carry naloxone? Yes, 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 no. Yeah. So yeah, so even in communities where some people or some law enforcement agencies carry naloxone, it doesn't necessarily mean all of them do, and it can be very difficult and usually a very inequitable process, right? Because we tend to provide services for people we see as valuable, and we tend not to provide services for people we don't see as valuable. So if you are a white college student, pretty good chance that there's naloxone somewhere in your vicinity if you need it. If you are a child of color growing up in an inner city community, good luck getting anybody to give a damn, right? And when we talk about where equity comes in, I think one of the most important things we can do is to just call it out when we see it, right? It's not okay that the reason that we've dumped not millions, but billions of dollars of funding into this opioid epidemic at this point is because we finally woke up to, to upper class white kids overdosing in college, right? We didn't care when it was homeless people, when it was Black and brown children. We didn't care at all. We didn't dump money into it. We didn't change our laws. We didn't do anything about it. And just saying that doesn't change anything, but at some level, forcing people to face the reality of what we're doing is one of the first steps that we can take to push those changes for equity and talk about, is this a fair distribution? Are we putting naloxone in the right place? Who's dying in our community? Are we getting the treatment to the people who are most in need of treatment? Where are our treatment programs focused? Do we look at what the bus routes are that go from where our populations live to where the clinics are providing treatment are? How do we do these things? And having those conversations and acknowledging that we failed miserably is probably the first step to any real change. In my community, and in most of your communities, if you look at your hospital drug testing results in your OB units, most hospitals order drug testing on expectant or delivering moms based on clinical suspicion, right? The doctor or the care team had a suspicion that individual was using drugs. I can't give you the exact numbers today because I've forgotten them, but it's somewhere around the level of Black and brown women are 20 times more likely to be drug tested at presentation at the hospital than white women are. Now ask me, which population of women is most likely statistically to actually be using drugs? Go ahead. Yes, white women. White women are statistically more likely to be using drugs while they're pregnant and at the time of delivery than Black or brown or indigenous women are. So what kind of a screwed up system allows me as a doctor to say that my clinical suspicion is higher that this woman is using drugs than that woman, if the outcome of that is that I'm 10, 15, 20 times more likely to test a woman of color than I am to test a white woman? Right? You don't know those numbers at your hospital? Figure them out. This is our job. And particularly for those of us who are white and affluent, which is a lot of us doing this work, right? It is our job because nobody is listening when other people say this. And if we're not saying it, we are failing the people that we are supposed to be caring for. Your coalition can be another avenue to actually spread this message. And I will be honest, I worked in an entirely white, poor community when I started doing, rural community when I started doing addiction treatment. I had no idea that children were being taken away from families of color at 10 times the rate that they were being taken away from white individuals in my county, right? I didn't know that. I didn't work with child welfare services. How would I know that? I didn't start realizing it until my rare female patient of color started having more trouble with my hospital system than my white patients were having, right? So I can't claim to have come into this aware and informed about what was happening, but you can't do this work for very long and not realize how biased the system is. And you can't with good conscience do this work and not call it out and make everybody face that. This is the last thing that I wanted to share that my community did, and I apologize. I had a family emergency this last week. I was supposed to bring copies of this for everybody. They should be available for you in the materials that are available after the conference, and if not, I'm happy to email them out, but I did not get them printed to bring, so I know you can't read this. It's okay, because what it says is not really important. We had a situation the middle of last year where the funding for syringe services programs to buy equipment ran out 6 months into the fiscal year in our county for our programs at both the county-based programs and the Catcher, which is one of our main harm reduction services in the county. And this predates me, so I can't really say what the history is on this, but there is a lot of antagonism between harm reduction services in our county and everybody else, except for me apparently. But so we had, and we started getting into these political fights about what is harm reduction, what's the value of harm reduction, are syringe exchange services just enabling people to keep using drugs? And we actually did a lot of community work around this topic, and we decided that we wanted to come up with a statement on harm reduction that was something that the organizations in our county could sign on to and endorse as a way of publicly taking a stand to support these types of services. And I wrote the initial draft of it, and it was really lovely. It talked about like evidence-based medicine and how it was the ethically correct thing to do. It was really good. You're just gonna have to trust me on this. And very medical centric. Our final version of this actually looks nothing like what I wrote. And honestly, I'm not 1,000% comfortable with everything that's in our final version, right? But that's okay because it isn't actually about me. This version was heavily contributed to by individuals affected by substance use in our community, with a focus on promoting the value of all individuals, regardless of whether they're using, not using, seeking treatment, not seeking treatment. And this became our community-wide statement around harm reduction. So when somebody on the political sphere or somebody in the businesses says, no one supports this, we don't believe in this, we can pull this out. Now, here's another embarrassing thing about this. Not only did my version not make it anywhere near the finish line, but I could barely get my organization to sign it. My board of 70-something-year-old white male physicians could barely get them to sign on. They wanted to edit it and put all the medical language back in. Well, they wanted to put some of the medical language back in. They didn't want to put any of the supportive language back in. But there's power in actually coming together as a community and saying, we believe in the value and dignity of individuals who use substances. We believe in their right to self-determination the same way that we believe in the right to self-determination of our patients who have other chronic illnesses. And we publicly support services that improve their safety, quality of life, and life expectancy, regardless of whether they choose to quit using substances or not, right? There's value in and power in our communities coming together and signing on to this and saying, we believe, and we will stand behind our belief publicly. We will put our name to this. You may not have much interaction with your county or city governments if you're in larger communities, but in smaller communities, we definitely do. So I regularly have to explain to my board of supervisors or individuals who are involved in politics in our county about why a service is important, about why it's meaningful. And I can tell you that most elected people look mainly at what their constituents say, right? So speaking out as a constituency and saying, this is what we believe, this is what your taxpaying organizations believe, this is what we support, has real power. We talked for a very long time now. I'm happy to field any questions, and what I would really love to hear from you guys is ways that you've used your coalitions, because I know that the way we've used our coalition is not the only way. So what have you done? What would you like to do? What do you think you could do with your coalition? Or if you don't know anything about your coalition, how will you go home and find out about getting in touch with your coalition? And with that, I'm going to open it up to questions. Yeah. To summarize, your Midtown Sacramento. I'm supposed to summarize for people who are online who can't hear your question. You're wondering about like what treatment options are available in Southern Humboldt County. Yeah. So there's a couple of different sites. So Southern Trinity operates some services in the southern end of Humboldt County, and then there is Redwoods Rural, and they also offer a buprenorphine treatment program out of Redwoods Rural, which is located right there in Garberville. That was easy. That might be the easiest question I've gotten in years. Anybody else? Yes. Wow. Thank you. I think again that speaks to the power of stories as opposed to data. And those of us who are clinicians, we need data. We need to know what works to know what to offer. And so our brains go to this. It's where we go. And we think that data is convincing to other people. And it took me a long time to understand that nobody cares about my data. Right? Because nobody cares. I have never changed a single mind by quoting facts and statistics at them. But stories are powerful. And again, great tie-in to that's what our cultures are for. And thank you. You made my day. I love that. So she just shared that in Lincoln and Auburn County areas, not county, city. Lincoln and Auburn, that they actually have a program where they're co-locating with schools in their safe spaces in schools to actually do early intervention with kids. And again, that is one of the most amazing examples of the ways that we get ahead of this problem, right? Because substance use tends to be a multi-generational problem. And we know that ACEs, adverse childhood experiences, heavily contribute to that. And I shifted gears in my career because, again, I got tired of trying to tell people they were the problem, we need to work with them to fix it, when what we really need to do is actually get in and provide early intervention, safety, support for children who are at risk. That's where we head off the problem. We don't head it off with treatment. Treatment is important because everybody is worthy of value and care and our compassion and empathy and appropriate treatment. But if we're going to ever get ahead of the problem, we need to get to our children before the substance use becomes ingrained, before they get to that point. I love that project that you're doing. I'd love to hear more about that when we finish up. Well, I'm going to probably turn my mic off then and step aside. I will be here for another 10, 15, 20 minutes if anybody has individual questions. And again, I'm happy to share my contact information because this is obviously not just a job for me. This is a passion. This is, I think, what we do to change the world. So nice meeting you all.